So my name is Dr. Miten Ruparelia. I've been a GP in Corby for the last 10 years. I'm one of the partners at this practice, which is at Woods End Medical Center. I also play a role in the CCG, which is the Clinical Vice Chair for the CCG. And today we're going to talk about the clinical peer review process or prospective review of routine outpatient referrals. So we've been a training practice for the last probably 2 decades now, and I think one of my biggest thing I noticed was the clinical variation we had in terms of the outpatient referrals as well as some of the non-elective referrals that we had in the practice. There was some pressure in those days during the PCT times in terms of trying to get some control on the numbers that were flowing to our acute trust. The biggest reason from the practice perspective was we wanted to firstly improve the educational elements that we give at the practice for our registrar, help to reduce some of the clinical variation that takes place within the practice so that our patients can get better quality of care. And thirdly was around the pressure that we had from the PCT in terms of trying to get some control of outpatient referrals from the practices. So I think like most patients will come up in a state of anxiety sometimes when they have a clinical need. As GPs, we try our best to be the gatekeepers to try and manage some of that as much as possible in-house. But there are certain times when we have a need to refer them onwards to a specialist review. Now that can, in instances, raise anxiety for the patient where they have to firstly take some time out to attend that appointment. They raises the anxiety about what the specialist is going to say or do. And thirdly, a hospital attendance isn't necessarily where a patient wants to spend his day along with. What this process does is it helps the patient to be appropriately firstly worked up as close to home as possible. And when the need for a specialist referral is required, it's absolutely essential and agreed as the MDT style within the practice. For example, certain pathways, we could easily now manage those patients in-house with some of the expertise we had in-house. Rather than those patients having to go all the way to the hospital to just be told that X, Y, or Z investigation is needed. Secondly, what it helps is it helps to dampen some of that I saw GPX who said I need to go to the hospital compared to I saw GPY who said no, I don't need to go to the hospital. So sometimes that can create confusion for the patient as to which advice they should take. This standardizes that. There's a patient choice element in this where patients can choose to say, no, I don't want to go to the MDT. Can you please refer me if you think it's the right thing? So we consent patients to make sure that they're on board with the process that we're following. Like most GP consultations when we have with our patient, we try and get a shared understanding of what the plan is. I think occasionally the patients can say, by going through this MDT process, will this delay my need, which needs a specialist input? We try and allay that anxiety by explaining to the patients that the MDT will enhance the process in terms of sometimes the care could be given more locally, which will prevent them having to go to the hospital. But if there is a clinical need for the specialist referral to take place, the MDT will make sure that that happens in a timely fashion and ensuring that there's no delay set in the pathway. And the administrative team will ensure that the referral takes place and the patient is informed in a timely way. So when we started the process initially, some of my partners were not too keen on doing it because they saw it as someone marking their homework or us marking each other's homework. In a way, their independence of being an independent clinician being eroded. I think once we went through the process and started off in a very open fashion, quite quickly all the clinicians within the practice realized that this wasn't about us trying to mark each other's homework or trying to gatekeep each other's work. It was mainly about improving the outcomes for our patients, as we highlighted earlier. I think we also realized that this was a critical piece that allowed us in our revalidation process of peer review in its active sense and also increasing our clinical knowledge in certain pathways where we were referring patients for specialist input, but through talking and discussing those cases, our knowledge of some of those pathways improved over a period of time. Also, when our registrars were presenting some of the latest evidence around what's going on with the pathways, it helped us collectively as a team to learn as an organization, and then to improve the quality of care we were going to our patients. I think the biggest benefit is having that open space and time to discuss something that's relevant to them, i.e. their patient needs. Secondly, them having that open and honest space where they can raise some of the nitty-gritty issues or some of the tricky issues that they're trying not able to in front of the patient, but they can do that in a MDT style. Thirdly, it helps with revalidation. All of us now have 3 learning points that come out of that MDT or post that MDT, and that helps us tremendously when we're sitting and doing our appraisal and our revalidation. And the final point is it's helped us to enhance as a teaching unit, as a practice, because we've increased our knowledge of some of the common pathways between each other by sharing that expertise.